Excellent. Well, good morning, everybody. My name is Dr. Frank Minja. I'm a neuroradiologist here at Emory. And in one of my other roles, I'm also co-chair with Leanne Lynham of the Global Health Committee for our department. And we are super excited today to actually launch our first in Global Health lecture series this year. And we have our guest, Dr. Fahad Marafi, who's going to be introduced by Dr. Raghu Halka, who's a longtime professor here at Emory Radiology. And myself, I'm very new to the Emory department, barely a year here, but I've heard a lot of like really excellent work that has been done in the past. And really, this is a work that's more than like 10 years, I believe, in the making. And we will hear more from Dr. Raghu as he introduces our guest, but it's just an example of our work in global health paying off. And we're also going to learn a lot from Dr. Fahad Marafi, because actually I believe that things that they're doing in Kuwait that we are not doing here at Emory. So we'll kind of hear some of those exciting things. So again, I welcome all of you. I really appreciate you guys tuning in very early in the morning here for this talk. I'm going to pass it on to Dr. Raghu. Please welcome Dr. Raghu.
Thank you, Frank. It's a great pleasure to introduce Dr. Fahad Marafi. For many of us, he's no stranger. He did his medical degree in Kuwait, Faculty of Medicine in Kuwait University in 1997. Then he did a little stint in pediatrics and then joined the exciting world of nuclear medicine. And in 2007, he completed his Kuwait Board of Nuclear Medicine. And simultaneously, he did Masters of Science in Nuclear Medicine. But around 2007, he and his colleagues, Dr. Abdul Rida, joined us for 6 months to get training in PET-CT. And that was a very exciting time for all of us. And then they went back and made a huge difference. So I'm a teacher. For a teacher, the most gratifying moment is when his student excels and makes a true difference. And Dr. Marafi and Dr. Abdul Rida have gone back and have done a true difference in the state of nuclear medicine in Kuwait. And we had the opportunity to not only to train only 2 of them, we trained another 2 physicians as well as about 4 technologists. So it was a team. And we always believed in nuclear medicine, that nuclear medicine is a teamwork. And after a few years, because of that invitation, we went to Kuwait as a group. Dr. Galt, Dr. Garcia, Dr. Ron Crow, we all went together again as a team of multiple expertise and visited Kuwait, and we were surprised how much change they had made. And very soon they were doing things that we were not doing here at Emory. So that was very, very gratifying that our investment in them had paid off. And then in 2015, Dr. Marafi and Dr. Abdul Rida came to Emory and gave us a lecture on gallium dotatate imaging, which we were not doing at that time. They also gave their experience with large experience in sodium fluoride PET-CT imaging. So in that way, they had already made a significant impact in the practice of nuclear medicine in Kuwait. And then now, Dr. Fahad Marafi is the director of Jaber Al-Ahmad Center for Molecular Imaging, which was in its infancy when we visited there. And I'm sure now it has grown significantly. And we would like to hear more from Dr. Marafi about the developments he has done in Kuwait. Dr. Marafi and his family has supported the humanitarian conference at Emory, which used to be held every year under the auspices of Dr. Schulman. They have contributed a lot for that humanitarian conference. The idea was to put all the voluntary organizations who do humanitarian work together and to exchange information and learn from one another. That was a great idea started by Dr. Schulman, and Dr. Marafi and his family foundation has been very, very helpful in promoting it. And now I'm sure Dr. Marafi will tell about Kuwait and uh, uh, as a country, as well as what's happening in the molecular imaging in Kuwait. So without much ado, I would give the microphone to Dr. Fahad Marafi.
Thank you so much, Dr. Halker. I appreciate the kind and comprehensive introduction. I hope you hear me clearly before I proceed.
Maybe a little bit louder.
Okay. I hope I don't shout, but I'll try my best. Okay. So it's my pleasure and my honor to be today in my second home, Emory Healthcare, to present something about molecular imaging and what are the current status. Honestly, as an introduction, we need to know that new molecular imaging is a chain of processes that goes starting from targeting the molecules we are interested in, into developing it into chemistry, and then biology, and using it preclinically, and then going into different phases of preclinical and clinical imaging, then having this on the table ready for the clinical use. So as I said, our center is called molecular imaging. However, I don't agree much with the name nuclear medicine and molecular imaging, since molecular imaging is branched into lots of specialties. I know we conquer the majority as nuclear medicine from point of PET and SPECT because of the variety of probes. However, I still appreciate what is available on MRI and opticals, which are really leading. There are some advantages and disadvantages for every single modality of molecular imaging, ranging from cost to the type of waves, either it's gamma or it's a light or it's sound, to penetration capability to the tissue. But the main advantage of having a PET is the high sensitivity, unlimited penetration, where you have a good and reasonable spatial resolution. You can do lots of probes. When you go to the field of optical or fluorescence, then you are limited by the tissue penetration. However, you have higher sensitivity, although we are still living in the preclinical world in those modalities. This is the Google map of state of Kuwait. I know many people are stereotyped about what's going on in the Gulf, but I agree, majority of the country is a desert, and we don't have a spacious residency among majority of the land because of oil fields and oil pipes and different other political reasons. But whatever goes within the range of that circle is the availability of around 11 departments of nuclear medicine. One of them is Shine and Red, where we are located next to the seaside. I need to say that the country is really having a long history of nuclear medicine, started in the late 50s. So we are not new to this. We have started radioactive iodine, and we have moved toward rectilinear scanners, and then moved to SPECT and SPECT-CT, and then PET-CT, not far away from well-developed country, if I could say that. In the country, we have 61 nuclear medicine physicians, around 186 technologists, 22 medical physicists, and we have around 26 radiopharmacists. The collective number of SPECT cameras between SPECT and SPECT-CT, we have around 47 in the country, 11 PET-CTs, 2 medical cyclotrons. One of them is low energy from Siemens, and one is medium energy from GE. If I want to focus on the center, which provide molecular imaging specifically and on a higher scale, we as a center belongs to a foundation called Kuwait Foundation for the Advancement of Science. This foundation is raised on taxing the private sector and using this amount of money into research and advancement of science. And as you can see, the aquarium or the scientific center in Kuwait belongs to this foundation. We have different centers. One of them is for diabetes, and we belong to the molecular imaging component. That's the, I wouldn't say tiny whiny, but I mean, that's a small center, one floor building. It's located on the seaside, very nice view, at least from my office. We park and enter this in a very smooth ride where the patient comes, take the appointment, and then come on the day of the test, get injected with the PET pharmaceutical. We have 2 PET cameras and 1 SPECT camera. I would like to say that Jabir Ahmed started with administrative plans, where we really, the base of the rocket, to put superior clinical service in our mind and try to provide unique radiopharmaceuticals and conduct substantial clinical research and facilitate the ground for training and clinical education. If we provide exceptional diagnostic clinical services, then we can eventually, with unique GMP class radiopharmaceutical production, we can develop the shape of research, the rocket to go to advancement by doing clinically oriented research projects, and at the same time have the knowledge and experience and provide good education and training opportunities. So as clinical service, I would talk about the human resource and say we have 4 nuclear medicine physicians, including myself, nuclear medicine technologists, number of 6. We have 4 medical physicists and 3 radiopharmacists. The cyclotron is run by a third-party company, which is the same company that has the agency for GE. So we are mainly a GE center of excellence, having all our production and image acquisition and reporting system from GE. So we don't have single gamma cameras or single head or only gamma camera. We have only 1 SPECT CT, 2 PET CTs. One of them is digital MI, and the second is 710 discovery. Our cyclotron is 16.5 MeV, as I said, from GE PET trace. We use PETRACE 800. We have 2 synthesizers of MX and the top-end FastLab 2 developer for research. And those are the cameras. This one is the MI camera, and this one is the 710. The difference, this is analog and this is digital, with both having 64 slice CTs. This is a SPECT CT 670, also top end. The clinical services are, the cameras for clinical services are accredited also for research. So we started 2019 and 2020. And in 2021, we are now EARL accredited for research standards using the ANM. For some KPIs, if I want to say like key performance indices, we want to say that our scheduling percentage is really more than 70% within 5 working days. So that's really very, very fast. And we have a good number of having less than 3 days for appointments. So from 19 and 20, we are still maintaining our excellent system. And now, because we are still struggling with the COVID situation, we are still trying to find a way to exceed 75 to reaching 80%, having appointment less than 5 days. Another KPI is time to release the report. In 2018, when more physicians joined and we collectively created a good number of smart and experienced physicians, we are having a good number within 24 hours reported. And then 2019, we have more than 85% reported within 24 hours. And in 2020, majority are touching the 90%. And now in 2021, we are above 90% of our reports getting released and submitted within 24 hours from the scan. That's really miraculous after only 4 years of practice. This slide was the help and assistance of Dr. Abdurrada by showing the COVID world data by the country in Google search, and you look in this site, you know where you stand. So we know that in Kuwait, the COVID impact really, to some consideration, has affected our practice, where we went into different waves, and we currently in the 4th wave or 3rd wave, as I imagine, and also that affected the statistics of having more and more death rates. The total cases before and during and after COVID, we see that in 2019, we are having 150 to 200 cases per week, per month for our patients. And then in 2019, 2020, we have a dip because of coronavirus. And then we have raised again 2021 in catching the curve above 160, 170 per month. The radiopharmaceutical production, I would say this is the map where we, as group, saw the center in 2015 by a prior administration who did their best to produce FDG over 4 years. But when we joined as experienced and dedicated people, we started in the same year, 2017, when I joined and the other group. The team were successfully able to produce sodium fluoride. Of course, all of these productions are GMP, good manufacturing practice class. In 2018, we managed to get fluorine-18 PSMA 1007. In 2019, we get an ammonia agent for cardiac perfusion, myocardial perfusion. And then in the same year, we managed to do parallelly fluorothymidine for cell proliferation. And within the I would say the gloomy year of COVID-19, we have managed to produce F-DOPA in 2020. So I would say out of the 6 isotopes, FDG was there, 2015, everyone knows about it. It's the main fuel for all our practices in oncology. And we have shifted in 2017, in June, we have shifted from bone scanning to sodium fluoride. And then looking at the evidence of having fluorine-18 PSMA 1007 being hepatobiliary secreted, and you don't have urinary contamination or urinary shadow, then the camera having a good acquisition ability for fluorine-18 over gallium, we moved to fluorine-18 PSMA as it lights in the green dot there, and you can see that it's beautifully, you can see the focus with the arrow within the prostate with no shadows from or contamination activity from the urinary bladder. Then we moved in 2019 into shifting the practice from SPECT MPI, myocardial perfusion imaging, into PET perfusion imaging using ammonia, and of course providing the coronary flow reserved. And we would like really to say that this isotope is really restricted by few factors. One of them is having the cyclotron on site and the short half-life of nitrogen-13, which is only 10 minutes. However, we have a really attached cyclotron, so we managed to do that. The other competitor is, of course, available in the chest hospital, one of our departments in the country from Ministry of Health. It's provide rubidium services. We moved to FLT, which we find solving lots of granulomatous or covocal lesions where you think that this is a lymph node, retroperitoneal, and you don't know if this is really a metastatic or rather than a granulomatous inflammatory lymph node next to the stent. And in the case of female with retroperitoneal sarcoma, This one was lighting up for many months and the patient was doing very well. So we advised to do FLT and it was totally negative. Patient's been followed up for the last 6 months and she's doing excellent. So that was one example of using FLT, one of many, many examples of using fluorothymidine cell proliferation probe in oncology practice. We have in March 2020 developed FDOPA, and we've used it in Parkinson since we have a good number of referral. And also we have moved with the European guideline of using it over FDG into brain tumors and specifically glioma. And you see here that FDG didn't show much, but in the same patient or in the same 2 patients, you can see the glioma very clearly taking amino acid transport. This is another example, revolutionary shift from ADAM 123, ADAM 131, AMI-BG in neuroblastoma. Now we are using FDOPA in neuroblastoma with brilliant spatial resolution. For research, we have done a lot, maybe being quite busy in 17, 19, preparing our machinery, but now we say that in 2019, we have published 9 publications. You can just write myself or Abdurrada or any of our team. And we have published around 9 publications. And in 2020, with the move of 1007 and different agents, we have moved into 8 publications. Of course, 2020 was challenging because of COVID, but 8 publication is a good number. On the academic approach also, we have started to contribute in the poster, international poster section in Society of Nuclear Medicine, and we have won one of the best abstract awards in 2019. And consecutively in 2020, also Abdurrada won, Dr. Abdurrada Ismail won another poster as one of the, I would say, 20 plus best international abstracts. And just this year, 3rd year in a row, we have won one of the best abstracts from our center specifically, and generally from the Middle East. I would say a success story started when we realized after being in 2008 at Emory, we came back from being fellows to speakers talking about gallium dotatate and dotatalk that we have been using at that time for neuroendocrine detection. And we have seen mainly Dr. Halkar, Dr. Schuster, and Dr. Lee, who were there with us in 2008, and new also comers. And we have presented about sodium fluoride as a new era of skeletal imaging. And Abdul was presenting about neuroendocrine, the use of gallium-68. We have also having the passion. In that moment, we had the passion to go and visit Wesleywood Health Center and Molecular Imaging Center, where we wanted to look and see what the others are doing. And when we joined in 2017, Jabir Ahmed Center, we have the background from Emory, from the clinical and academic/research approach. So we have really worked together, as the website at Emory called it, benefits from a positive return. So we have really came back, even in 2015, looking at another bout of enthusiasm given to us by Emory. Besides 2008, we came back and we have pushed all our limits to see what we can do and give to our country. I hope that I have presented a very short and concise lecture about what is going on in Kuwait from molecular imaging point of view. Thank you.
Thank you, Dr. Fahad, for this excellent presentation.
Dr. Halkar,
I'll
we cannot hear you. I think it.
Okay, thank you. So thanks, Dr. Fahad, for this excellent presentation. And I will open the floor for discussion. So I would give first chance to all the people to ask you any questions. And one of our aims for this particular presentation was to have a continuous dialogue between Emory and Jabir Ahmad Molecular Imaging Center and build on what we have already laid the foundation. So I would like all the participants to go ahead and ask some questions or give some ideas how to grow from here, how to grow, improve our relation or grow our relation for the betterment.
I could start. Hi, Fahad. How's it going? Can you hear me? It's David.
Yes.
Hey. So one thing that might be helpful for our audience is if you could explain the medical system in Kuwait. You know, how do patients pay? Do they get billed? You know, that kind of thing.
Yeah, basically in Kuwait, the clinical medical services are free of charge for the nationals, and they are for certain fees for the non-nationals. And if you ask specifically about the PET CT, it's around $500 for the PET scan itself.
Mm-hmm. So each year there's like a budget that's kind of given out to each center. Is that how then you develop the budget based on how many patients you think you're going to take care of, that kind of thing?
Exactly, that's the way it goes. The governmental plan that has been approved every single year.
Right.
Fahad, I have one question. I'm very happy to see that your center has been steadily growing. In Kuwait, you said there are about 68 nuclear medicine physicians. Can you give me the gender ratio? How many females and males?
I would say that the nuclear medicine specialty or branch in Kuwait is a female dominant specialty. They are majority among technologists and the 61 physicians. I don't feel the difference, but I would say that the majority are females. And recently, with the growth of Kuwaiti board nuclear medicine being handled by North American graduates, it's been really boosting and accepting more graduate than our years. And then now it's a 5 years program, so it's quite challenging to recruit and then find them after 5 years with very well trained people at PET, CT, and molecular imaging also.
That's good to hear that you have, you know, achieved a fair amount of diversity already in Kuwait in terms of gender disparity that we sometimes struggle in US. So that's an interesting point. I have a couple of questions. Have you thought of therapy in your center right now or not?
Honestly, the molecular imaging is translated definitely into molecular therapy or molecular theranostics. I forgot to mention that we have joined Cancer Control Center when we came back from Emory, so I have to give it the credit of all our experience in vast approach, experience with cancer centers, cancer patients, and also MDT meetings was being a fruitful experience because we have really immersed ourselves within core oncology practice. But if I would say that Cancer Control Center is now the center for either CERT, internal therapy for the liver, or lutetium dotatate for neuroendocrine, or for PSMA for prostate cancer. So that's the main clinical service. But if we want to move into molecular theranostics, I'm licensed to use lutetium and actinium, but again, we have to follow the IRB, the ethical approval board, and these kind of things where we really can do it in a very protective and legal way.
We have one question from one of our residents in the chat asking, can you throw some light on why F18 PSMA 1007 does not get excreted in the bladder?
I'm not in the position of explaining the radiochemistry of that, but we know that fluorinated PSMA has lots of advantages over gallium, being produced in bulk dose and having longer half-life. And we can, since we all our department are using automatic injector, so we are using a bulk dose and injecting in a very reasonable amount of millicuries or radioactivities. Beside that, the hepatobiliary excretion, I think it's only unique to 1007, or maybe there is another radiopharmaceutical, but the huge army of pharmaceuticals that comes for PSMA imaging is mainly using the urinary system. I cannot answer honestly why is the reason why it's hepatobiliary, but most likely there is a reason why it's been modified by the group at Heidelberg, because they are the same group that produced PSMA 11.
Yeah, and there is an answer that is mainly excreted by the hepatobiliary route. And if the question is why, it's a stereochemistry approach probably. I would like to take this opportunity to throw some light on the relation with Kuwait Foundation for Scientific Advancement. And I don't want to, as you correctly said, we don't want to restrict this relationship only to nuclear medicine. As you said, that molecular imaging also takes into consideration optical imaging and MRI and other radiological procedures. And also I see that Kuwait Foundation for Scientific Advancement has vested interest in the diabetes research. And we would like to get some more information how we can develop Emory as a group can develop a relation with the Kuwait Foundation for Scientific Advancement. And I would throw this idea open to all the listeners. And if they have association with basic scientists, physics, or clinical scientists at Emory, they should contact probably Dr. Fahad or any one of us, and we can hook you up with the Kuwait Foundation for Advancement of Science and try to use this platform for getting better research out of it.
Thank you. This is Saima Muzair. I'm one of the faculty members here. Thank you, Dr. Murphy. Excellent talk. And Kuwait is very close to my heart because my program director actually, I was trained in Pakistan before I came to US. And my program director actually moved from Kuwait. He used to work with Dr. Halkar. And a lot of our colleagues have actually moved to Kuwait after completing their postgraduate training in nuclear medicine. So I know a lot is going on in the advancement of nuclear medicine in Kuwait. One of my actually colleagues, Dr. Muhammad Omar Khan, is in Al Jahra Hospital. I don't know if you know him or not. And I'm in constant touch with him, and they are doing great work as well. One of my questions is, are you guys doing PET MR or moving towards that direction?
We hope to move into the PET MR. We have focused recently more on PET CT over the years. We found from our experience that investing that amount of money on PET MR was so early. We were waiting for the other regions to give the feedback, and eventually now we have one PET MR installed at Jahra, waiting for proper staff, well-trained staff to work on it. We are already occupied with our digital MI, doing fast scans, really low dose scanning. And since the queue for taking patients per day is more than 18, 20 patients a day, with 8 to 2 working hours, I mean, 8 a.m. to 2 p.m., that's a very short time for working. But again, we do 18 to 20 per day. So we were occupied in this. But if you speaking about advancement, definitely Jabra Molecular Imaging Center is looking for having different approaches to have new technologies. It's not only PET MR, but also whole body PET systems, or even dedicated like breast imaging devices.
All right, thank you so much.
Go ahead, please.
Slides that you had a large number of radiopharmacists and physicists on staff now. Can you comment on those professionals?
Well, I have to be really transparent with you. I mean, dedicated medical physicists in Kuwait are limited. Majority are like nuclear medicine technologists who acquired master or PhD in medical imaging or radiation protection, but they are doing their best to facilitate a couple of issues in all departments, from calibration, running phantoms, and doing the usuals. But we understand your questions, because maybe we had a chat, Dr. Galt, about it once, that we hope to have very well trained people from your side, because we have always believed that Emory is not stopping at only physicians level or clinical services, but I mean, they help at different professions. So what I would say, even that applies to radiochemists. Most of them are like, I don't exaggerate, but some of them are really lab technicians, or like pure chemists who are interested in labeling and doing things. But what is behind the curtain at the third-party company that run the show? No, they are professional radiochemists, and they have a medical physicist there. If you are talking about Jabr itself, no, we are lacking the properly trained people, but we are titling them according to units. So either they are titled under medical physics or radiochemistry / pharmacy.
Dr. Marafi, this is Ron Crow. How are you doing? It's great to see you. I know you can't see me. I'm in my office. I don't have a camera in my office, but I'm going to use Dr. Galt's kind of, I used him as an intro here, since you're asking about that. As I am the PET radio pharmacist here down at the Center for Systems Imaging. And I wanted to say that was a great talk. And it's really exciting to me to see how all the advances you have made since my visit there many years back. And I want to formally invite you to come and see, once we have it completed, the new CSI core radiopharmacy that we're putting together, that we're building in the new HSRB2 building. It's going to be quite a facility, and really we'll be able to take this translational pharmacy, radiopharmacy, really to a new level. So it's just really great to see you, hear your talk, and I look forward to seeing you in person and giving you a tour of the new facility sometime next year once we get it completed.
Thank you for the invitation. I'm really looking for it. Thank you.
Hey, Dr. Fahad, it's Frank. Again, on behalf of Emory Radiology Global Health Committee, I'm really, really thankful for your talk. That was very inspiring. Can you please just touch upon whether Kuwait takes care of regional patients and how this all ties into like oncologic care within the region and all of that? Thank you.
I can speak from this angle as the president of Kuwait Society of Nuclear Medicine too. So I would say that in the Gulf, now we have good centers in Saudi Arabia, in Bahrain, in Oman, United Arab Emirates, Qatar. So basically the Gulf or the Middle East are really well developed in PET-CT practice. But what I know that the only molecular imaging center that's is well established is in the Arabian Gulf or Persian Gulf. That's in Kuwait, but I know that there's one trying to rise up in Jeddah, in the western side of Saudi Arabia. Of course, if you compare us to Israel or Turkey or I don't know, to some extent to Republic of Iran, it's sometimes maybe the literature or the presenters or the research ideas we see in posters or lectures, we can tell that we are at least hand in hand going in the Middle East region with these 2-3 countries, where we managed with our small population and higher ambition to provide really good platform for molecular imaging.
Fahad, at this time, I would like to take an opportunity to touch upon one of your other expertise, which many people may not be knowing, is your experience with International Atomic Energy Agency. I know Kuwait has hosted quite a few programs, seminars from IAEA, and you have been instrumental in getting it. And I know you are an expert for IAEA. Can you tell in a few minutes your experience with International Atomic Energy Agency?
Yeah, basically, I started joining as an expert to International Atomic Energy Agency. IAEA provided different opportunities to be speaker, for me to be a speaker into different workshops. But then when I moved as a Director General for the Molecular Imaging Center, I found that there is a collaborative agreement between IAEA and JAC. And they have been really somehow sluggish and slow because of the COVID processes, no in-person attendee. However, we have passed the Quantum with a good score. Quantum is the quality control nuclear medicine mission. They come and check your departments, and they evaluate every single thing you do, from the patient entrance into technical details, reporting, and we have scored very well. And the only 2 centers in the country who passed Quantum are JAC and Kuwait Cancer Control Center. So we have been working with them, and our hopes are really high that with the help of great schools like Emory, we can develop good standard for radiopharmacy and medical physics in the country, at least, or even the region.
I point out that those are the 2 places that you and Alder Riva have been involved, or the 2 that you mentioned is passing. And one thing from your talk, you mentioned accreditation by EARL, which many of the people online might not know what EARL is. So if you would.
EARL was started as a standardization of the cameras, mainly PET CTs. And when they focused mainly on FDG as the main fuel, and they wanted to standardize using phantom data, having the cameras on a certain standard standardable in all these countries or centers who are planning to participate into research. But again, it's now being grown into using it in sodium fluoride, in gallium, and even in thinking of doing it for rubidium and ammonia. And that's the standard where not only for research, but at least to maintain a good standard of your acquisition cameras compared to other European countries.
There is one question, Fahad, from Dr. Saima Muzair. How is the nuclear medicine residency program structured in Kuwait?
What I know, as a brief introduction, that it has started before 1990, and there are many graduates at that time. Till my batch, where we graduated in 2007, it was a 4 years program, very well structured, but there was no molecular imaging approach where you do basic clinical training. It's a 4 years program with 2 exams for part 1 and part 2. And now it's been increased to 5 years. According to many training systems, you need another extra year either in research or in hybrid imaging, as they call it. You do more radiology, more cross-section, either MRI or CT. And also you get more involved into research, and it's not a dissertation, but they prefer you do some kind of academic approach. Beside also having more and more therapy now, compared to what we used to do, like basically only iodine-131 therapy and bone palliation.
Thank you, Dr. Murphy. So that means now, because as you are moving towards from more 4 to 5 years of training, maybe there is more rotations in the oncology as well, or is it primarily in the radiology? More time would be spent in radiology.
Honestly, we found the difference between the prior program and the new program that it is going on the Canadian standard, where they need to have more, what I would say, North American standard, where they need to do more of hybrid and cross-section imaging, and also have some element of research.
All right, thank you.
Dr. Marafi, I'm from the East Africa region. I'm always wondering whether we could replicate something similar. Can you give us an idea of the financial investment that went into jumpstarting your efforts? Like, what's your annual budget? Like, what would make this sort of feasible? Just to kind of give us some of the numbers, because you said that I guess private sector is taxed to support the Kuwaiti advancement of sciences. Just to give us the numbers part of it. Thank you.
Basically, the center is being funded totally by Kuwait Foundation for Advancement of Science, KFAS, and KFAS is a body that collects yearly the tax on incomes from the private sector, that's including the oil sector. So they have an approach, something like NIH. Of course, it's not purely dependable on research. So they contribute heavily on research and help lots of grants from national or international candidates, but also they help in the education sector. They are helping in medical sectors, like what we do and diabetes do. And also they are working on basic science, like having a good academy for innovation and people who innovate, and they help them to register their innovations. So if the question was about the budget, there is a difference between a budget that's allocated to a center and a budget that's allocated to research. If we apply for research, we will have a fast track, of course, as a daughter institute. However, we don't usually go directly and ask for funds. We have a certain fund for our administrative and clinical and pharmaceutical production. But if the question was how Emory can be involved, or other universities can be involved in research, either for therapy or basic science or clinical imaging, then we can do it through grants, through memorandum of understandings, and then we can do a very good collaborative work. That's also added to education. We can also host through some way. We can host people from Emory, at least returning some of the favors from Emory. They help us to how to initiate ourselves. Now we have to pay back and help our Emory healthcare.
Got it. And so the patients who come and get scanned, most of them end up being research candidates. Are they research subjects, or it's actually it's a clinical service that you charge for the clinical service, I guess?
Honestly, we do a big chunk of clinical services just to maintain the flow and having variety and heterogeneity of patients. But yes, we do lots of candidates for research. For example, we do PSMA in non-prostate cancer malignancies, like renal cell gliomas, and we have big projects. We do even new isotopes for bone scanning, not released yet, using gallium, called gallium zildronic acid. That's really one of the points in the future, but we need to declare it when we are ready.
Thank you. Thank you.
I have a question about, are you still using a generator for, let's say, dotatate? How do you didn't mention dotatate, but you are, doing DOPA. So how do you handle neuroendocrine tumors?
Yep, that's a good question, Dr. Schuster. I think when we started in 2014, the dotatate, and then we moved to DOTA-NOC, we've been working mainly in cancer centers. So when we moved, we didn't want to do something redundant. So we still accept few cases, and we ask for single doses to help our clinical cases. But the new approach that's coming very soon, maybe in 2022, to install a liquid target on our medium energy and produce our own gallium, because we feel that gallium is a good platform for research, and we want to do in-house production rather than generator. But the answer to the question, cancer centers still work on generators, 30 millicurie generators, and they send us the doses whenever we're ready.
So thank you very much, Fahad. If we will keep in touch, and I'm sure many of us have a lot more questions, and we can do it one-on-one. And I'll hand it over to Dr. Minza.
Thank you so much, Raghu, for hosting the meeting. And thank you so much, Fahad, for that wonderful and very inspirational presentation. And I also want to thank Dr. Schuster and others who I have yet to meet at Emory, but clearly people have been working on improving healthcare in the Kuwait region for many, many years. And I hope this collaboration continues. I'm hoping Dr. Raghu will definitely seed some continuation of this, whether we start to send some of our residents over to Kuwait and to kind of like learn about some of the new techniques. But I think it's a very, very exciting and quite inspiration. I've definitely taken a lot of lessons for how you guys have organized. You have a very organized approach to everything. So I think that's also like very instructional for us. We work very hard in the East Africa region where very much we're battling things on a day-to-day basis and not in this sort of like long-term strategic fashion. So if anything, what I've taken from this talk is just being strategic and being very long-term in your thinking, in your training, and also putting in a lot of like research well established into operation. So without further ado, I really want to thank you, Dr. Fahad, and also for taking the time out of your busy schedule. I'm sure you have a lot of busy stuff to do. And I want to also thank our audience who tuned in like super early over here to join the session. So without further ado, we will close the meeting. But thank you so much, and we'll be in touch in the future. And we hope to either host each other or come and visit your facility in Kuwait. Thank you so much, Dr. Marafi.
Thank you.
Thank you. All right. Over to you, Dr. Raghu. You may close the meeting. Thank you so much.
Okay, thank you.
Thank you.